So when this first happened, I came into it with feeling like I was on a boat, like walking on an unsteady boat. It wasn't spinning. It was just holding myself up on the ground. I got off the couch, and then it was just this whole earth shaking kind of like feeling of being on a boat, which is crazy to me, right? And in my head, I thought brain.
That's me on the left. I've been battling dizziness and vertigo for 13 years. Recently, I wrote a book about it. Today, I get to ask the questions I've always wanted to ask. Is a physical therapist the right person to see for help? On the right is Daniel Ludwig. He's from Johns Hopkins and agreed to speak with me. Let's find out.
So first, actually, I want to thank you for the time, right? We always feel rushed and everything. And also, obviously, I wrote that book, The Patient's Guide to Vertigo and Dizziness, and you were lucky enough to like it. And then all of a sudden I knew you existed, which meant I had to send you a message and say, hey, can we have this opportunity? So thank you for that. I thought maybe a quick introduction on your part on who you are, where you work, and then maybe I'll recap some of the topics, the general kind of framework that we talked about, just to maybe keep me honest and hopefully keep us on track, because I know there's going to be a lot of good information. Is that fair?
Sure. Sounds good.
Okay, go for it.
My name is Daniel Ludwig. I'm a physical therapist. I will have been practicing as a PT for 11 years coming up this fall. I work at Johns Hopkins Hospital in Baltimore, Maryland. First 7 years of my career, I spent in the acute care setting, working inpatient and in ICUs, mostly with patients with neurologic diagnoses. And then several years ago, I decided to make the switch to outpatient life and work primarily with patients with dizziness and vestibular disorders and balance disorders. So that's what my current practice is. I see patients 3 days a week, and I help out in a research lab here at Johns Hopkins for 2 other days.
Nice. Thank you. So basics, I think we were going to try to get to the basics, and part of that was who you are. And then we would get into a little bit about Johns Hopkins, because I think there's a differentiator between single practitioner and then practitioner within maybe a center or something like that. The anatomy, what the definition or what the terms of vertigo and dizziness kind of mean to you and sort of in general, the testing that either you're comfortable with or the center can provide and things of that nature. Along with the conditions and any recommendations you have. And I think between the testing and the conditions, the conversation will probably get a little bit more interesting for me and maybe some patients. But I think a lot of this is going to be background 101 for all of us to kind of level set on what our expectations are when we talk to folks like yourself or go to a center like Johns Hopkins or that rehabilitation center you work at.
Sure.
So you mentioned Johns Hopkins. When I think of physical therapist, I think knees, ankles, back, hip, but vestibular. And I'm going to have two personalities here, hopefully. One is me 12 years ago, 13 years ago, when this first happened. And then me, 12, 13 years later, after having read and gone through all the appointments. So if you asked me 13 years ago what a physical therapist was, I'd say knees, ankles, toes, hips. I pulled a muscle, I got a bruise, or I have a surgery, and I need to get mobility back. Vestibular was not a word that I really even recognized, but that's not true, right? So you said PT. You've also got in your signature here DPT NCS. Maybe you could tell me a little bit more about how that relates to vestibular or vertigo and dizziness, and just maybe some basics on what that is.
Sure. So an NCS is a board certified clinical specialist in neurologic physical therapy. So that's a huge umbrella for a lot of different types of diagnoses. You can get that you have to take an exam in order to get that. You have to have a certain number of hours of practice in the specific population, so neurologic patients, or have completed a neurologic physical therapy residency to be able to sit for that exam. So I got that back in 2018. And that encompasses all types of neurologic diagnoses, from strokes to brain injuries, brain tumors, multiple sclerosis, et cetera, all down the line. And under that umbrella of neurologic diagnoses, vestibular kind of lives under there.
Okay, that's interesting. So are there other, and here I am 13 years ago, I thought, okay, physical therapist, and I don't know who told me about it, but I thought, okay, well, I'll give them a shot. It wasn't my first go, right? It wasn't like I go into a doctor's office and I think vestibular therapist. I think physical therapist. I think NCS. I'm at that point thinking MD, right? Like doctor. Are there other acronyms? Are there other certifications or accreditations that patients should be aware of that when we're Googling, right? So let's trust the search engine, and that's going to be a main, source for us. We don't have yellow books and phone books anymore. Is there something else? Is there a different way to find you or someone like you? Is there a better way?
The most reputable ways are to use the Vestibular Disorders Association website, which is VITA. They have a tab where you can search for clinicians of any type, whether that's MD, OT, PT, etc. And that's reliable. And then the American Physical Therapy Association has different academies for the different types of PT that you've kind of been alluding to. There's a sports section, there's a orthopedic section, we have our neurology section. And under that academy, there's a vestibular special interest group. And they have their own webpage that has a map of providers that provide vestibular rehab as well. So those are probably the two most reputable places to search. We have this neuroclinical specialist title that you can get, but other people do practice as vestibular clinicians. Some of them are orthopedic clinicians who end up seeing a lot of dizziness and vertigo because they see patients with neck issues, and sometimes those things are interconnected. So the be-all end-all is not necessarily a neuroclinical specialist, though they should have a pretty decent understanding of the system. But those two websites are probably the first go-tos that I typically use when I'm trying to find clinicians for patients who come to see us at Johns Hopkins, but they live much further away. So follow-up care with me in my clinic isn't necessarily possible. How can I set them up with the best resources closer to where they live?
Yeah. And I might get into this on the testing side, because the concept of is, Johns Hopkins, you're in Baltimore, right? Maryland, right? So if you're in the United States, you would know it. East Coast, if you're not, maybe you're a West Coast person, but Johns Hopkins carries weight to it, right? There's a name, in my head, I'm on the East Coast. So in my head, I think Johns Hopkins, smart people, right? Answers. They're going to help me out here. If I've got to go somewhere, I'm going to go to the smart kids, right? But you may not live within 2, 3, 4 hours or driving distance or have the ability to go there. And I think maybe eventually when we talk about the testing side, it might come out. But tell me more about Johns Hopkins, because I think there's going to be something maybe that Johns Hopkins has or does. And I don't know, and clarify, everybody where you work, they're not all NCS, right? So like I can't necessarily call Johns Hopkins Rehabilitation Center and then trust the scheduler to set me up right, or can I? Like, how does that work?
So, yes, you're right. At Johns Hopkins Rehab Network, and I just want to, before we dive too far into this, I'm putting the little plug out there, the CYA.
So when this first happened, I came into it with feeling like I was on a boat, like walking on an unsteady boat. It wasn't spinning. It was just holding myself up on the ground. I got off the couch, and then it was just this whole earth shaking kind of like feeling of being on a boat, which is crazy to me, right? And in my head, I thought brain, right? I think, again, no idea what to really think.
So if you were to call, the way that it works is we have scheduling questions, right? And decision trees that we try to use to funnel the patients to the right provider. So if you say that you call and you say, I'm having dizziness or I'm having vertigo or I want to see a vestibular therapist, then there's subsequent questions to try to direct you to the most appropriate provider. Does that work perfectly every single time? Obviously not.
Right.
But we do try to direct people based off of some of the initial questions that we ask to get in with the right type of therapist. And if not, we all kind of talk to each other and say, hey, this seems like this is coming from the vestibular system, or they're having dizziness. This isn't my wheelhouse. And then I'll get messages or emails from colleagues asking how we can get them set up for the right type of evaluation.
Oh, that's interesting. So that's different from the Johns Hopkins perspective. So I think, again, I've already said, I think Johns Hopkins has smart people and are very good at what they do, but I've never been a patient. And I never really knew earlier in my journey that I needed to or should go see and like invest in a place like that, a dizziness center, balance clinic, right? I didn't really know that they existed, where they were, and what the difference was between going to this big fancy place that had a lot of resources and just going down the street. And I think through this conversation, I start learning, and through over the years, I start hearing that there are differences. And maybe that detail, some of the people that are earlier in a journey, like I was, I didn't really appreciate the value of one visit here versus one visit there. One visit here could be significantly more effective if that person has an eye or a training that's more than just a class. These are maybe more dedicated people that have dedicated resources. Like, for example, just the questions that the scheduler might ask might be a little bit more effective at funneling them to the right practitioner, because there are so many more practitioners there that have those specialties. Sure. There was something else that we talked about before this, which was, and I don't want to start muddying and going off track, but the resources and different departments that Johns Hopkins has. It's not just one hospital. It's not just like an ER. It's maybe not just your rehabilitation center where you work at, but there are other practitioners that aren't emergent, that aren't, in the track that you would think to go, but it might be part of the experience of Johns Hopkins. And I think that's an interesting concept because, again, mental health will come up in this conversation. Imaging or not getting imaging sometimes, and I found myself going down a rabbit hole, going from one center to the other because I'm piecing together. But having a vestibular center, knowing what I may need, will be interesting. And I think that's just a differentiator. So I digress. I don't want to go down too many rabbit holes. But I did want to talk about anatomy because to me, so I have a whole chapter in my book about anatomy because I didn't know any of this existed. Like, not a shred of it. No one taught me about a vestibular system. No one told me that, one, I didn't know it existed, two, what was involved in it clearly. So when this first happened, I came into it with feeling like I was on a boat, like walking on an unsteady boat. It wasn't spinning. It was just holding myself up on the ground. I got off the couch, and then it was just this whole earth shaking kind of like feeling of being on a boat, which is crazy to me, right? And in my head, I thought brain, right? I think, again, no idea what to really think. So when this first happened, I came into it with feeling like I was on a boat, like walking on an unsteady boat. It wasn't spinning. It was just holding myself up on the ground. I got off the couch, and then it was just this whole earth shaking kind of like feeling of being on a boat, which is crazy to me, right? And in my head, I thought brain, right? I think, again, no idea what to really think, but I think eyes, brain, like what is this feeling? Where could it possibly be coming from? Because it was completely foreign to me. Maybe help me understand a little bit about what you think about from the vertigo dizziness perspective, what anatomy is involved in what you call vestibular, and then maybe in addition to that, where you focus on, if there's a general or maybe a specific spot that you focus on in your work.
Gotcha. So first, that's the beauty of the system, is that you don't know you have it. It's one of your senses, right? It's that sixth sense that we have that you don't know exists until something goes wrong with it, right? You know you have taste, you know you have hearing. You experience those on a much more intentional level on a daily basis, right? But balance just happens, right? You don't remember how you learn to balance. You don't remember how you learn to walk. So that's, to me, the beauty of that system, is that when it's working appropriately, it is invisible. It just works, and you don't have to think about it. And the trouble is when you do have problems with it, that it becomes very, very noticeable, right? It's gone from something you didn't ever have to think about or notice at all before to something that is constantly now bombarding your system and your psyche. When we talk about the vestibular system, we tend to break it into two different components, okay? There's the peripheral vestibular system, which is the end organ in the inner ear. That is comprised of 3 semicircular canals on each side that measure or track head rotations or angular acceleration. So thinking quick movements of your head saying no, yes, or turning your head. There's also 2 organs in there that are called otolith organs, and they are tracking gravitational movement and translational movement. So I tell patients, thinking about how you sense that you're moving up or down, like you're in an elevator, forward or backwards like you're in a car. And obviously that's a little bit overly simplified, but that's generally how the system works. And then you obviously do motions like tilting your head to the side that end up being a combination of both that gravitational type of sensor as well as the rotational type of sensor. That is called the peripheral system, as well as the nerve that carries the information from that peripheral system and takes mechanical information and transduces it into neurologic information, impulses or synapses. And we consider that nerve, which is called your vestibular nerve, up into the point where it synapses or connects to your brainstem. That is considered the peripheral system. And after that, there are widespread connections through your spinal cord to coordinate balance reactions, to nuclei in your brainstem to coordinate eye movement reactions or reflexes, and then even bigger spread of this system up through the cortex of your brain. That becomes a much more difficult system to describe and to measure. And that sort of relates to your sensation of where am I in space, my spatial orientation, my ability to navigate, and how does my brain put together multiple systems in order to tell me whether or not I'm sitting straight in this chair or if I'm tilted off to the side, or in your case, right, this sensation of being on a boat, even though if you kind of sat there and thought about it on a strictly cognitive perspective, you'd be like, I'm not moving, but I feel like I'm moving. And that's
Right.
a little bit more complex.
So you said peripheral. You also said brain, which is central, right?
Central.
And then you said something. So for the first 7 years of my journey, and one of the first visits I had was a neurologist, and he's like, oh, because what happened was I slipped in some steps, nothing crazy. I'm a big guy, but I just slipped. I didn't hit my head or anything. I didn't tumble down. Nothing like even a wrestling match would cause, right? But he said, oh, you know what? You threw your neck out. That's, occipital atlantal dysfunction, atlanto-occipital dysfunction, upper neck, right? And on that note, I thought, well, that makes sense. Okay, I threw my neck out, right? I focused on that part of my body because I thought, well, that's okay. I didn't really get that, right? I don't understand the neck and balance because I played sports for a long time. I never had this issue. Why all of a sudden now is my neck? I didn't do anything. It wasn't anything crazy, no car accident or anything devastating. But you said brainstem. There's a whole population of people, they get hung up on cervicogenic and the neck, but then there's the eyes, right? And then there's the inner ear, and then there's the muscles and the neck and the nerves. And it seems like, and this is where I never understood, was there's a whole bunch of stuff. Like you said, there's a whole network of things. And in that network, there's like dependencies. And I never really got how intricate that dependency was, like that whole net of connections. Would you say when a person comes in from your perspective, is there a scope that you work on? Like you yourself, Daniel Ludwig, do you kind of say, all right, when my head, my scope and my experience is neck, nerves, or ear, or are you kind of all over? You say you're specialist or generalist, let's say that.
I would say that I'm a little bit of both. I specialize in being able to assess for each of those systems independently of each other, right? To see if we can figure out specifically where this problem may have started or is currently coming from. But I'm a physical therapist. I can't just say, oh, well, I tested your ear. It's not your ear, so good luck, right? Which unfortunately, and I'm not saying that this is all PTs or all MDs, but unfortunately sometimes that happens, right? We all end up with a little bit more of a narrow focus. Well, it's not your ear, so good luck. We'll see you later, right? I know that there's this interconnectedness. And as a physical therapist, my job is not to necessarily diagnose the problem, but it's to help my patient feel improved from their symptoms and to be able to move more effectively. So we treat patients' symptoms and their functional impairments, right? And I don't always have to know the specific mechanism to start doing that process. So I can rule out that it's the inner ear system or the peripheral system. We can do some tests to say it's probably not primarily coming from the neck. You might have other conditions like migraine or 3PD, which we might get into a little bit later, which are contributing to why you're feeling the way you feel. And we can do more work to try to dissect that, but we can always do some type of education and or movement type of treatment or relaxation type of treatment for patients whose symptoms are extremely high to be able to start that rehabilitative process. So I have what I suppose would be considered specialty skills in some of the assessments, but I have to treat the person in front of me as the entire person.
Yeah, that's really interesting. And maybe this is a topic that comes up, but as a patient, I don't know that I fully appreciated the responsibility that I kind of had to be aware of these things and ask these questions. Like I kind of expected somebody to kind of just map it out for me and tell me, or to just figure it out and get it done, right? Like I just want to go back to life before this thing started, like just the day before, I'll be fine. But I don't know that I kind of expected it to be like your knee is broken or you've got to sprain your shoulder. And again, I'm coming from not a whole system-wide interconnected network type of thinking. I'm thinking one item, fix it, right? Something broke, fix that broken thing. And then I'm sure the rest of it will come into place, right? But I think it's just naturally for me, and again, maybe it's other patients, maybe it's not, it was a whole different concept. And that challenge became this gap because I didn't really get what we were doing. Like I wasn't hand in hand with the practitioner as they were kind of doing their thing. And maybe it would help, and maybe it wouldn't. I don't know. It's probably a waste of time because you guys are trying to get the actual result going versus like sitting there and educating me for an hour on a recorded call. Like, that's not really part of like everybody's assessment evaluation. But it was challenging for me to wrap my head around there. And now, like 10 years later, 13 years later, I can see there was value in, at least for my brain, the way I think. You mentioned something though and I'm curious, where do you start? I mean, there's a whole bunch of places you could look at. You probably do. Is there a standardized way that you look at that anatomy that physical therapists do, or the sort of specialized vestibular folks do? They start saying easy to hard, or critical, potentially central to not as much? Like, how do you guys start?
Yeah, easy to hard, I would say. There's a relatively standardized exam that we do to assess things like how your eyes move. Are they moving appropriately? Are they moving conjugately? Are they moving smoothly? Can you hold your eyes in certain positions, which you should be able to do? Can you jump your eyes between targets? Right. And so for some of the initial tests, we're looking for things that might be considered central or coming from the brain. And then we're moving to the inner ear system. And the main thing we're testing with that are the vestibulo-ocular reflex. If I move my head, do my eyes stay on a target if I want them to, no matter how fast I move my head? So if I hold my thumb up in front of my face and I move my head quickly side to side, I should be able to see my thumb clearly, no matter how fast I'm moving my head, if my vestibulo-ocular reflex is working. So we test to see whether that reflex is working or not. And then the other thing with the inner ear that we primarily are looking for is BPPV, which is benign paroxysmal positional vertigo, where little crystals that are called otoconia that are supposed to be in our inner ear on those gravity sensing organs that we talked about before, they fall off into the canals, those rotational sensing organs, and they cause a false sense of movement or vertigo when you change head positions with respect to gravity, right? Those are the primary conditions that affect the end organ or the peripheral system that we're looking for. After that, once we get into the central things, there are certainly central things that are urgent and scary that require immediate workup. And then there's central things that are more similar to vestibular migraine or 3PD that are chronic, kind of percolating for a long time, that I don't need to send you to the emergency room for, but I also can't say that it's coming from your inner ear. So to kind of break all that down and make it a little bit more simple, we're looking to see if the VOR works. And if it doesn't, then we're thinking that you have what's called a hypofunction, where one inner ear system doesn't work as well as the other one does.
Yep.
Or we're looking to see if you have a positional vertigo, where when you change head positions, you get brief spinning episodes that are sort of reproducible by doing things like rolling over in bed, sitting up out of bed or laying down, bending your head forward, like picking something up off the floor, or tipping your head far back to look up at a shelf. Or we often hear, dentist chairs, or I was at the hairdresser and I was getting my hair washed and I sat up and the room started spinning.
Yeah.
So those are the two main peripheral things that we're looking for.
You just said dentist chair, and I don't want to talk about too much until we talk about conditions, but I just saw a post just the other day, and some of the comments were, I hate going to the dentist because it's always that way. I need to find a dentist that's aware of vertigo and dizziness, because I need them to maybe not tilt the chair all the way back, or to not have me sit up, or give me 10 minutes after I do get up because I'm not feeling great, right? Something's off. So maybe we can talk about it later, but you brought up the vertigo and dizziness specifically now, and sort of the BPPV, and what one is and kind of another versus the dizziness, and it kind of maybe want to ask you to maybe expand on that a little bit, because over the years, and again, I'm taking my 13 years into this journey personality here and saying, I've heard so many different definitions of it, and I've also heard interpretations of saying, practitioners saying, it's extremely important for you to describe dizziness or vertigo. Like, I need to know specifically what you're talking about, because it might affect my treatment. But then there's others who say, you don't need to have a spinning room to be considered vertigo. And some say, no, that's absolutely not true. Like, for me, what helped finally 10 years in was I personally found the definition of vertigo to be spinning helpful in maybe eliminating some things it wasn't. And by that, I'll talk about it later in conditions, but I had a long list of potentials, right? WebMD was like this long of all these things it could be. But so I was working my way down through like the phone book of what causes dizziness. But maybe in your words, what does vertigo or dizziness mean to you? Do you need definitions? Are there specific definitions? Just maybe back to the basics on this for us.
Sure. Dizziness is a very broad, overarching term that encompasses a ton of things. And it can come from the ear system, it can come from the brain, it can come from cardiac or pulmonary conditions. And so we don't often like the term dizziness because it's not specific enough. The definitions that I kind of use and will kind of cue patients towards so that they can start to differentiate their own symptoms if they're having trouble doing so is vertigo is a false illusion of movement, and it doesn't have to be spinning, but we kind of break vertigo into two different categories. Spinning vertigo, which is what most people are referring to when they say vertigo, right? And non-spinning vertigo, which is sort of what you were experiencing, this sensation of being on a boat and rocking or swaying, is still an illusion of you moving or your environment moving that probably wasn't actually happening very much. So both of those things can technically be considered vertigo. But most frequently when people are referring to vertigo in a discussion, they're referring to the spinning type.
Right.
The other thing with vertigo that I find frustrating personally is that vertigo gets thrown around as a diagnosis. Oh, I went to the emergency room. I wasn't feeling well. I was dizzy. They told me I had vertigo. And I'm like, okay, well, what did they do? The term vertigo is not a diagnosis. It's a symptom. And so there's more work that needs to be done to make sure we're getting to the root cause of what's causing the vertigo in order to more effectively treat you. So that's just a quick aside. Other types of dizziness that we kind of use are unsteadiness. Do I feel off balance when I'm moving, or even when I'm just sitting? Lightheadedness, which is that sensation of I'm on the verge of maybe I'm passing out. I stood up too quickly. The room kind of gets dark for a second and then comes back. Just that sensation like I'm not getting enough blood flow to my head. So those are the main ones that I try to break things down into those categories for people. Some people also describe like a brain fog, or their head feeling heavy, or swimmy headedness, or they'll describe feeling drunk. And so there's a bunch of different terms. I try to stick to the vertigo, the lightheadedness, and the imbalance in terms of the three main things that I'm looking for.
I want to keep asking questions. I'm going to save it for the condition section that we're going to do, but part of me wants to keep asking about the anatomy and the conditions and the way that we describe it. But now I think I'm actually doing your job. Now I'm tiptoeing into a place that I'm not you, but I am curious about it. So I appreciate the definitions and your perspective on vertigo and dizziness. And I actually, even to this day, so the first, you just saying that, I always considered what I had in the beginning just dizziness, like the walking on a rough boat. You saying that you would actually acknowledge that as vertigo, or as a type of vertigo, was really interesting to me just now, right? I don't know if my face expressed it or not, but I never really thought of that as vertigo. And I definitely never explained it to any practitioner as vertigo. And I don't know that they even explained it back to me that the way you said it, that could be considered vertigo. It was usually like dizziness, off balance. And I'm like using whatever words I know, trying to describe it. And they're, for the most part, looking at me like, okay, I don't really know. And again, I'm not talking to a vestibular specialist, so the conversations were challenging, right? They're just hard and frustrating for me as a patient.
Well,
okay.
Just as an aside for that, there's these broad terms that we can try to use to classify your symptoms. But when we get into sort of the world that you were just kind of describing, where you're like, it feels kind of like this, I'm not really sure. When we try to get too far into the weeds as to exactly what you're feeling, that's when it becomes a little bit less helpful in terms of both treatment and diagnosis, right? Everybody experiences dizziness or imbalance or whatever you're going to call it slightly differently from the next person, just like everybody experiences pain differently, right? You could say, I have a high pain tolerance. Well, some people might have a high motion tolerance, or vice versa. So getting too far into the weeds can sometimes lead us astray from some of the more important questions to be asking during a subjective history, which are, when do you get the dizziness, right? Does it happen certain times of day? How long does it last for? And what are you doing when you have that dizziness? Are you just sitting doing absolutely nothing and then all of a sudden the room starts going around for 40 minutes? Or, I feel dizzy all the time, but it gets much worse when I do X, Y, and Z activities. Those types of questions end up being a little bit more helpful than getting into the weeds of, well, do you feel like you're moving forward and backwards on the boat? Or do you feel like you're moving side to side? Is the room spinning? Is it spinning clockwise or counterclockwise? Those types of highly specific descriptions of what you're experiencing tend to have less accuracy in figuring out what the problem might be than the timing and the triggers for the dizziness.
That's interesting. Timing or the triggers. Timing is in how long the duration?
Yep. Or like how long that it, like what time of day that it's happening potentially.
Oh, that's interesting too. So now it sounds like you just mentioned something that's subjective background, and I want to talk about testing or tests. You kind of talked about it before. Some of the first things you look at is that VOR. Is the eyes matching? Are they moving when your head is moving? But then there's also, you just brought up the background check, right? Like when you go in, and if I make an appointment and I show up on your door to Dr. Ludwig's office in your room, and now you've got this person that's coming off the street, and I'm telling you the things I'm telling you, right? I'm walking, it feels like I'm standing on a rocking boat, or I have this rotational. I probably filled out a form or two, and you're probably looking at it on some clipboard, and you're now trying to figure out, what am I going to do with this person, right? Okay, he's firing off information at me, and maybe you're like, I know exactly what that is, or I have a very strong feeling this person was amazing at describing these things, and I know the duration, I got the timing. This guy watched George and Daniel on YouTube, and now I know exactly what I need to come prepared with, right? And they do. But is there a standard? I'm going to bring up Johns Hopkins because I'm curious. is there a standardized approach that maybe you at Johns Hopkins takes or all vestibular specialists take across the country? Is there a form that you guys have that says, man, you fill these out accurately and I have I have a much better opportunity to treat you effectively? Or is it sort of a canned form that gives you a background? I remember doing this and it was like, your pain tolerance. And I'm like, I came here for dizziness. Why am I talking about pain? It's like, oh, well, your disability is your pain better. I'm like, again, no pain, just dizziness, right?
Right.
And I'd go to a different place and it's a different form, a different place, a different form. Is that still the world that you live in? Is it different Johns Hopkins? Is that just sort of vestibular specialists everywhere? Or
I mean, a lot of clinics, depending on the scope of what their clinic is and how large their network might be, have certain forms that, especially now with online type of scheduling, that, all right, well, we have to pick one thing that we're going to give to everybody. And 80% of the patients we see are orthopedically based. We're going to give them this orthopedically based form that's about pain. That makes sense.
Yep.
But I think to answer your question, there are questionnaires that frequently get used. And there's several new ones within the last 6 to 7 years that can be helpful in doing some type of discrimination. Now, you can't rely solely on those questionnaires, right? What PTs and physicians are trained in doing is taking a lot of different information from different places, from patient reporting, from the questionnaires, from my clinical exam, from my observation of the patient, and putting together a pattern of what they're seeing that fits with certain diagnostic patterns. But in terms of the questionnaires, the ones that most frequently get used are the dizziness handicap inventory.
Okay.
And then we also use something called the activity-specific balance confidence scale that asks about your confidence in maintaining your balance during certain activities. Two of the newer ones that have come out, I believe 2019 and 2020, or maybe 2022, are more specific to vestibular migraine. That one's called the Vempathy, which sounds like empathy.
But with a V?
Yeah, VM for vestibular migraine. And I forget what the pathy exactly stands for, but it's a burden of symptoms measurement, right? How much symptom are you experiencing across certain different domains? It's 25 questions, and you rate those symptoms 0 to 4, and you get a total score up to 100. Higher scores indicate that you're having a higher burden of symptoms. That was created by an ENT that specializes in dizziness and balance disorders at UCSF. And then there's what's called the Nagata 3PD questionnaire, or PPPD questionnaire, that's out of Japan. But that's a questionnaire that's 12 questions that is more specifically related to symptoms for persistent postural perceptual dizziness. So, we can give patients these different types of questionnaires and see where they score on certain areas and start to narrow down what our thought process is. Now, you kind of said, are there forms that you can use? Are there questions you can ask that are going to start to, what I would call, refine my diagnostic hypothesis? Yes. The interesting part is that once we get to that testing we were talking about before, it should be pretty standardized. Everybody assessing the initial pieces of vestibular are going to be doing the same type of exam. They're going to be looking at eye movements, and then they're going to be looking at how the eyes respond to different stimulations with head movement or head position change, and a few other types to figure out how that system is functioning.
That's fascinating. I'm actually really happy to hear that. And we'll talk about the conditions, but we go into any appointment as a patient, and we hope that you guys have a bag of tricks / tests where we go in and you guys will completely understand it, right? That there's a gold standard test. And here I am, again, 13 years ago, going in and thinking, well, what's your test? Like, let's rule this in or out definitively. And I should leave. And here I am in this interview asking you, in this conversation, manage my expectations. If I were to go back in time there are, I'm sure, plenty of tests, right? And we can go through maybe some more and specifically and the popular ones that you feel people need to know about. But for example, the questionnaires, even us knowing that they exist, I've never, and this went up until this point in this conversation, I didn't know that there was a vestibular migraine analysis, right? An assessment. And for those at home that might Google it and think, do I have this, right? There may be something that they can look up and research and know that exists and think, okay, well, does this give me a clue? Because for me, for example, I'm going around for 7 years saying I got cervicogenic dizziness. I'm very confident in that because somebody said my neck and I kind of ran with it. But there wasn't a cervicogenic dizziness test that I was aware of, right? And as there wasn't a vestibular migraine test that I was aware of, or even a questionnaire, that I can't say that I'm going to take that and say I've diagnosed myself, because that could be dangerous, right? We're not practitioners. You still need to see somebody to help you with that. But it does help you maybe on the anxiety side, kind of firm up some of the things that you thought were happening and maybe validate that, okay, it could be a migraine, because you hear terms, I'm talking about the conditions, but you hear people throw things around. I went down rabbit holes with TMJ, with cervicogenic, with, the SCM muscle and all these different things. And I'm investing time and money and hopes and dreams of it being the thing that it is. But there wasn't one place that I went to that said, I've got 45 tests. Let's start with these, right? Because these are going to be, like you said, let's go with the easy ones. And as we go through that, if it becomes more and more challenging, well, we're ruling things out. And there's also things that we're ruling in as we get these results back. So give me 3 hours or 2 hours. And that's going to be a question here is, what can you perform there? If I go and see Dr. Ludwig at Johns Hopkins right now, and I show up on your door, is there something I should have done before I got to you? Is there something that you're going to be able to do there on your own? Or is there something I'm still going to need to do after to help maybe with the treatments or even a diagnosis, right?
That's a very dependent on chronicity kind of question, and how well educated the patient is about their own condition before they come to the appointment. I don't think it's fair to put the onus completely on the patient to be 100% prepared before they come for an appointment, especially if the symptoms are new, right? That's my job.
Yeah.
Now, when you leave the appointment, I might still say, hey, we ruled out X, Y, and Z. So I'm not very concerned about those things, but we still need to figure out a little bit more. We need to build a little bit more of that pattern of your timing, of your triggers, to figure out what's the best way that we can help you, right? So I might send you with homework, so to speak, to be able to figure out a little bit more. So you might not always leave with a definitive diagnosis, but you should leave with a plan to figure out what my next steps are.
Yeah. No, that's interesting.
Now, to your sort of patient preparedness before the appointment question, for patients who have been dealing with symptoms for some time and are seeking care from multiple specialists, the more of that pattern that you can provide, right, timing and triggers, how long symptoms last for, the more of that pattern you provide, the more you're playing into that diagnostic process that's in the clinician's head to help figure out what that problem is. And I believe VITA on the Vestibular Disorders website has some references or some materials that patients can use to either look at and review, or actually have like a form, I think, that they can fill out to say, here's my symptoms, here, like, this is what I came prepared with.
Yeah. Well, that's cool.
People can look on the Vestibular Disorders website to try to find that type of information and reporting, so that for patients who are chronically experiencing symptoms, you can feel like you're going a little bit more prepared to your appointment.
Yeah. Do you think, and I want to bring up the anxiety, and I'll tell you why, is because 7, 8, 9 years, and I got true rotational vertigo. And it was positional, right? And I was like, man, at this point, I have a pretty strong sense of what it is. And I was relieved. As sad as that sounds, I was relieved, because I was like, oh, that one makes sense. It wasn't what I had. So somehow it became something that I didn't think I had. But either way, I was like, oh, I think this one's more accepted, right? This one, somebody can grab onto and figure out and treat. The rotational vertigo made me a little bit happy. It was an awful feeling. But even in that series of tests, Like, I didn't want that feeling to happen again. And I kind of knew going into it that I was probably going to have to feel that again. And now for BPPV, that's kind of what I thought I had. It's positional. The tests I saw online, I Googled them, I went on YouTube. They looked easy. Like it would be a normal procedure or process if I were not suffering for this. Like if I was a 10-year-old, 12-year-old person doing cartwheels, I'd be having my head move in different places. I wouldn't be that worried about it. But now all of a sudden that I have the sensation, I'm extra sensitive to any movement, right? And you could be like, oh, move your head left and right and see if your eyes move. You can believe that I'm guarded. Like I'm not moving my head. I'm moving my whole upper body to absolutely not move my head. But I know I need to challenge myself for these appointments. I know that going in, do you guys ever say, hey, look, or do you guys ever acknowledge, look, you're not going to like me today because I'm going to push you guys into places that I know you don't want to go. Like your body right now is actively resisting because you're scared and your body doesn't know exactly what's going on, but I'm going to do this today. Is that part of the testing process for patients? Like, should we be aware, like, look, buckle up, it might get ugly today?
I don't know if I would present it the exact same way, but yes, some of the tests and some of the treatments, or most of the treatments, kind of require that you experience those symptoms again. Do we want it to be an anxiety-provoking experience? No. So we'll try to do the best that we can to educate you as to why that's important, that it might happen, to what level it should happen for it to be considered more effective, to put you in positions where you feel as safe as possible, and also explaining that anxiety response, I tend to use the term fight or flight response, right? So that I'm not doing any kind of stigmatizing. Some patients don't want to be labeled as being anxious. And it is a physiologic response, and it's normal when you get really dizzy like that. So reinforcing to patients that what you're experiencing is normal and expected. And what we want to do is over time, make that normal expected only happen when it's supposed to happen and not happen all the time.
Yeah. I think one of the big fears I had personally, and maybe others share it, but I felt that even though I knew I was going to have that feeling there, I thought it would stay even after the appointment and you guys would send me packing. And I'd be like, man, I feel better. I don't feel good at all. And I definitely don't feel normal, but I don't want to feel worse when I leave. Mm-hmm. And that's that mental component. And we'll probably talk about next. We're going to talk about conditions here in a second, but man, that idea really stopped me from like making myself available to treatments and even maybe an effective diagnosis. Cause I'm thinking, I really need to trust you, practitioner. Like I really need to know that you've got all the things you need to do today, because if you get it wrong, and I leave and you're like, all right, well, I'll see you in a couple of weeks. I've got 2 weeks I've got to still deal with, or a month or 6 months to come back and tell you, hey, look, it didn't work, or I'm not sure what to do here. And then either I wait or it gets better, or I've got to go now find a different practitioner and say, hey, look, I just tried this stuff over here. You're the next one up and help me, right? And then it starts over again.
Yeah, I think the only thing we can do as practitioners is be completely open and honest and say, hey, you've got a complex BPPV. I don't think I got it. I don't think I successfully treated it today. You might still have symptoms, right? When you go home, and I'll see you next week and we'll try to fix this again. If I'm open and honest with you, that's the best that I can do to set expectations that, look, I know what I'm looking at. I also know that we may not have had the most effective session today. Hopefully that gets you to buy in and trust the practitioner, is that they're open and honest about that. What you're describing is a very difficult thing for patients to be able to overcome. And it's not always possible for the practitioner to just sit there and be like, stop worrying about it. It's not going to happen again, right? Yeah. So the best thing that you can do as the practitioner is to be honest about that.
Yeah, no, I think I appreciate that. And I think it probably would help a lot to know that either you guys are available emotionally to hear some of this stuff, because again, it's just tied into our mental health. I mean, there was a guy on one of the forums, he works in like a cement truck driver. And I couldn't imagine going from a treatment that didn't work and then having to drive a truck where you're bouncing around and you're all over the place. And that's just normal daily life, right? So like one person could work in an office where it's relatively straightforward. Another person could be outside with loud noises and loud banging and then moving around. And you're like, well, their 2 weeks is going to be much different than the other person's 2 weeks, right? Okay, conditions. Boy, between testing and conditions, and again, I brought up WebMD. Here I was doing the best I could, Googling and trying to figure out what conditions or what was going on, right? And I got a laundry list, 2 pages long, from very terminal, very, very aggressive, and like worst case scenario to, it could just be, you have allergies, right? And everything in between. Boy, like as a patient, I don't know what to do with that, right? Like I don't know where to start. Like general practitioner, my doctor, okay, let's see what they say. And then they're like, well, I'm not sure. Like I've got a current practitioner. She's amazing, very, very intelligent person, but vestibular issues aren't her wheelhouse. I mean, there's just no fault in that. It's okay. And she's been clear about it, but she's also supportive in going and finding that specialist. Some practitioners aren't that nice, right? They're like, take a beta histamine, take some Flonase or take some Claritin and, be on your way, and I'm sure it'll be fine. Sorry, right? How do I approach it? And the conditions for you specifically here, you talked about a couple. Rehabilitation center, and you also mentioned vertigo and dizziness is a symptom necessarily. It's not really the condition. Do you see a lot of people come back with, other conditions and then you find it? Do you see them as vertigo specific, or, what do you see from a condition side, from you specifically there?
Well, we're a large tertiary medical center with 3 departments that see a lot of dizziness and balance patients. So I think Johns Hopkins sees somewhere around 3,500, 3,800 dizzy patients per year. That's a lot.
Wow. That is a lot.
Between PT, ENT, and neurology. So we see a lot of your similar type of situation, right? I've seen XYZ, I've seen this provider, that provider. I still don't have a clear understanding as to why I feel the way that I feel. So we see a lot of the chronic, complex, multifactorial dizziness where maybe there's a migraine component. They've probably at some point morphed into this PPPD or persistent postural perceptual dizziness realm. We see patients who do have BPPV. So we see a good mix, but we do get a decent amount of the chronic side of the dizziness thing. For patients who are entering this journey, right, the 2 most common conditions that cause episodic dizziness or vertigo are BPPV and vestibular migraine. And depending on which prevalence studies that you look at, vestibular migraine is sometimes just slightly above BPPV, and sometimes BPPV is just above vestibular migraine. But those are the 2 most common things that cause episodic dizziness. So those should be at the forefront of people's mind. And vestibular migraine is hard because people are like, well, I don't have a headache. And that's probably an episode all in of itself as to how to go about the vestibular migraine piece of things. But those are the 2 most common ones.
So many questions right now. So vestibular migraine, 13 years in this journey, I might be a bit more intelligent about what I think that is or where to go. If I just started, I have no idea, especially because migraine to me equals pain, right? In my head, I think, okay, but I now 13 years into this know that migraines don't necessarily need to be painful, right? There can be a silent pain or silent migraine that has some similar, symptom of like vertigo, for example. You say you might be able to see that person. In my head, I think neurologist. I think migraine is brain, right? I mean, why not? And then I've seen comments say, yeah, I mean, they can do it, but neurology might not be the place. Maybe it's PT. And it almost sounds like you guys can do quite a lot there. Well, are you still the best first place?
I'm a good first place. I'm not the only place.
Oh, okay.
Management of vestibular migraine is multifactorial, and it depends on the severity of the patient's symptoms and the frequency of their symptoms, and how their symptoms from the actual migraines themselves might bleed over into daily life and become more of a chronic symptom, right? But having worked in this space and seen large numbers of patients with these types of conditions, I know how to recognize some of those signs. And I know when lifestyle education, right? What are the triggers? What brings on your dizziness? Oh, it's when the barometric pressure changes. It's when you're more stressed. Like, let's try to work on some of these lifestyle things before we get you on medication, right? But in general, the management of vestibular migraine is multifactorial. Usually there's a medical side, right? Are there supplements I can take? Are there medications that should be trialed to control for the actual episodic dizziness, migraine-related things? And then what is the functional impact? And that's where physical therapy treatment might be more important.
Yeah, the functional side. Yep.
But for me, from a diagnostic perspective, I feel like I have the tools to at least recognize this isn't coming from the ear. You don't have any scary central signs. Vestibular migraine should be considered. Here's some education about what that is. Here's some of the things you can try to do that don't require that you take any medication to figure out a little bit more about your timing and your triggers. And at the same time, let's get you to a neurologist who can more accurately diagnose this and initiate some type of medical management, whether that's supplementation or medication, depending on what their expertise and evaluation shows.
Nice. I'm going to guess it's the same thing for like TMJ, Meniere's, and mal de Barquet. All these terms are thrown around, but at the end of the day, it sounds like you're going to be a good person to go to help identify these things, rule them in, rule them out, and either be part of this treatment with you or be able to understand where to go next.
Yeah,
so
I would agree with that.
I kind of want to talk about your recommendations. We got a few minutes left. I want to make sure that we hear any recommendations you have for patients, both chronic and the new ones. What do you think? Tell us where to go. Tell us what to do, right?
Sure. If you are a new patient, if you just started having dizziness symptoms, get in to see a vestibular PT or an ENT or a neurologist who understands dizziness as soon as possible. The sooner you get seen, the easier the diagnosis is going to be, and the more support you're going to have through the process. And that lessens the risk of developing more of a chronic dizziness syndrome if you can get seen more quickly, right? Because if it is something like BPPV, it can be treated effectively and quickly, and the residual symptoms or the worry about, all right, when's this going to happen? Right, that you kind of described with, I don't want to move my head. Those symptoms can be alleviated much more quickly and prevent that progression to the chronic dizziness.
That's interesting. And it sounds like mental health is a big component, right? And I think that's one where maybe this video, maybe others, just to understand that the practitioner side understands this and should understand it. That's something we can hold the practitioner accountable for, is knowing that there's a sensitivity to this for us through this journey before chronic or new. This is weird, right? But then also that the treatment side of things for us as patients to understand, and this is something that we own, is that there's no magic pill, that this could be, even in the simplest form, be interconnected in some sort of a system. And it could affect, and it might affect eventually something else that wasn't over here, right? Your neck might get tight because your eyes are off or your ear is off. And don't be weird or don't feel weird that something doesn't make sense. This isn't supposed to really make sense to us because our system is trying to make sense of something that doesn't make sense. It's just the nature of this thing.
Yep. Yeah, for the chronic patients, I think I would say that the process to improvement takes time and it takes effort. And it takes experiencing some things that are uncomfortable. You're a good physical therapist who treats patients with chronic dizziness syndromes understands that well, I'm speaking for myself. I shouldn't say this for all PTs. The biggest thing that I can do in that first evaluation, if I think somebody has a chronic dizziness syndrome like triple PD, is get them to buy in to the fact that this is going to be a process, that it's going to be slow, and that there's going to be bumps in the road, right? Because if you, as you kind of alluded to before, if your expectation coming into the appointment as a patient is, all right, my knee's broken, fix the knee and I'll be good, and that's what you leave the appointment still thinking, there's a pretty good chance that my rehab program is not going to work for you, because I'm expecting it to take weeks to months for patients to feel much, much better in those scenarios. And if your expectation was, well, I'm going to feel better in a week, then we're on different pages, and that's not going to mesh very well. So the more that a chronic dizziness patient can understand that it's a process, it's sometimes an uncomfortable one, but that each step is moving you towards improvement, I think is the biggest key. And that you should have somebody who's willing to walk you through those steps. Maybe not hold your hand the whole time. I'm a big proponent of this kind of tiered approach where I might see you, if you have chronic dizziness, once a week for 4 weeks to kind of set this tone and this baseline. But you have to go do this on your own in everyday life if you want to get better. And so I might start after the first month being like, all right, go try this. I'll see you every other week. And then after the second month, all right, I'm going to see you monthly now, right? This is an active rehabilitation process for patients to go through and to have to do with guidance from a practitioner. But we don't have the magic bullet in these chronic dizziness disorders. It's lifestyle guidance, management, and exercise in general that probably play the biggest role.
But I think I heard you say weeks and months for those patients that are suffering for years. We may need a better practitioner, or we may need to be able to, have that conversation with somebody, maybe like yourself, or go on to Vita and say, years is a long time. If they're still uncertain of the actual, if it's a BPPV, if it's something that might be considered treatable, years might be a bit long. There should be some more help that they could seek out, and to reach out to places like, a rehabilitation center, vestibular center like yours, like at Johns Hopkins.
Yep.
Cool. Well, thank you, Daniel. I really do appreciate it. It's been an hour, so if anybody's still watching, I imagine they probably logged off, but I think this was great. Thank you so much.
Yeah, my pleasure. Thanks for having me.